Shut up, sit down, start listening. This will change your life.
Hello, and welcome to Mindray's series of webinars on advanced point-of-care cardiac ultrasound. My name is Jane Emma Perry, and I am the clinical marketing specialist for Mindray North America's point-of-care ultrasound division. I am excited to be joined for this series by Dr. Rob Reardon, Professor of Emergency Medicine from Minneapolis, and Tom Paul, Emergency Physician's Assistant from Glenwood, Minnesota. Throughout this series, we hope to dive into cardiac ultrasound by focusing on how various methods and techniques are used in the clinical assessment and treatment of patients in the acute setting. We invite you to leave questions or comments in the chat, and they will be answered via email afterwards. This is a three-part series designed to focus on key clinical scenarios where point-of-care ultrasound can significantly impact patient care. In Part 1, we focused on evaluating the septic patient. In today's webinar, we'll move on to evaluating the dyspneic patient. Finally, in Part 3, we'll focus on the patient presenting with chest pain. So let's begin. Part 2, the patient presenting with dyspnea. Shortness of breath is one of the most common reasons patients are seen in the emergency setting, and its causes are numerous. In this video, we discuss assessing these patients and arriving at a diagnosis with the help of bedside ultrasound. Today, we begin, naturally, with lung ultrasound. Then, the discussion will continue to how various methods of cardiac assessment relate to your patient with shortness of breath. You will hear about the evaluation of cardiac size and function, how diastolic function can be assessed, a discussion of valve disease, diagnosing pulmonary embolism, and finally, effusions and tamponade. Before we dive in, a brief review of a few of these topics that may be new to some listeners. Diastolic function refers to the ability of the heart to relax and fill. It is a key part of understanding a patient's overall cardiac function and guides treatment, fluid resuscitation, and medication options. There are several ultrasound clues to pay attention to that can help you understand a patient's diastolic function, such as LV thickness, LA size, and the severity of a TR jet. A dilated left atrium should always raise suspicions when looking at the heart. When we talk about measurements, we generally look at the mitral valve inflow pattern, which gives us clues about LV filling pressures, and tissue Doppler, which tells us about cardiac function in relationship to those pressures and helps to interpret them. We'll discuss these in this webinar. A basic assessment of cardiac valves can often aid in the workup of a patient presenting with dyspnea, as shortness of breath is the most common symptom of almost every kind of valve disease. You can leverage any or every mode on your ultrasound machine to give you information, from paying attention to B-mode clues to using continuous wave Doppler to assess velocities and pressures. This slide shows some of the ways B-mode, M-mode, color Doppler, and continuous wave Doppler are used to assess valves. Finally, when assessing shortness of breath, you have to think about the right side. Evaluation centers around looking at size, function, and pressure, and ultrasound can help you better understand all of these. Now, let's hear from the experts.
Okay, let's go to the second part of our discussion here. We're going to talk about dyspneic patients. So we're going to use a case of a 72-year-old woman with acute dyspnea for 3 hours. She says she's never had this before. She's a little hypotensive. Her oxygen saturation is a little low. Her heart rate's a little high. And her respiratory rate is high. So something's wrong. She's an ex-smoker, type 2 diabetic, hypertensive, so a lot of underlying problems. So what's the differential? A lot of things, right? So pulmonary edema, which could be caused by LV function, whether it's systolic or diastolic. She could have a valve problem. That's a common cause of dyspnea. Pulmonary embolism is a common cause of dyspnea. Pericardial effusion, dyspnea is actually the most common complaint with effusion and tamponade, impending tamponade. And of course, myocardial infarction is always on the table because People, a pretty good percentage of people with acute myocardial infarctions don't have chest pain, and dyspnea then is the most common secondary complaint. So you have to think about all these things.
Dyspnea is such a common presentation, and I think it can be very difficult to work through. But again, having a systematic approach really allows the differential to become narrowed. I mean, that's a lot of the advantage of point-of-care ultrasound, is that it's a lot of binary questions, like, is the heart function normal? Is there a pericardial effusion, yes or no?
Yeah.
Does the RV look bigger than the LV?
Yeah, and without point-of-care ultrasound, you can really make some big mistakes in patients like this. So the POCUS will get you started in the right direction. Okay, so my approach in patients like this is generally start with the lungs. That's the easiest thing to image. We said this before, the heart is more difficult to image. I would look for, do they have a predominance of A lines or B lines? That's simple. Anybody can do that. If there's B lines everywhere, hey, they have pulmonary edema, you made the diagnosis. It doesn't tell you why, but you know why they're short of breath. If they have A line predominance, you know they don't have pulmonary edema, and then the differential, is P, tamponade, maybe pneumonia. And then, if you do see pulmonary edema, then you can go deeper and look at the heart and figure out, what's causing the pulmonary edema. And the IVC can be helpful. For example, if you see somebody with an effusion, a pericardial effusion, and you think it might be tamponade, and you go look at the IVC and it's small, can't have tamponade with a small IVC. So that's when it's helpful. It's not helpful in everybody, though.
And I think with this straightforward approach, looking at the lungs first, where you don't require any window, unlike most other ultrasound,
Yeah.
it's pretty simple. You see sliding, no sliding, right? Do you see A lines or B lines? And what's the distribution of those B lines? And it really takes you in certain directions and takes you away from bad directions and bad diagnoses.
Yeah.
And just completely relying on x-rays, which are horribly unreliable at the bedside, the portable chest x-ray for pulmonary edema, pneumothorax.
Yeah, if you start looking at B lines and looking at chest x-ray interpretations, it's kind of sad. I've noticed just the last year that I've seen people with really no B lines anywhere, and their x-ray is read as, consider pulmonary edema or, something like that. They just don't have pulmonary edema as their problem. If someone shows up to the ED and they have dyspnea as their acute dyspnea as their complaint, and they don't have B lines, they have just some scattered B lines way at the bases, that's not their problem. If they showed up for dyspnea, you'll see, and pulmonary edema is the problem, they'll have B lines everywhere. So it won't be subtle. And the chest x-rays readings are just all over the place.
And I think labs can send you down the wrong road too. The hyperdynamic left ventricle causes the BNP to be elevated. And in that person, if you relied solely on the BNP, you may not fluid resuscitate them when that's actually what they need.
Yeah, so you really need to pay attention to lungs, ultrasound of the lungs, heart, and IVC will lead you in the right direction. Okay, so this patient, she has pulmonary edema. Okay, this is the upper lung fields on both sides look like this, and of course the lower ones look even worse. So her problem is pulmonary edema, right away. The question is, what's causing that? Her heart could look like either one of these, right? So we know that 50% of the people who show up with pulmonary edema with heart failure have preserved ejection fraction. So, if you're just looking for a poor LV systolic dysfunction, then you're going to miss half the patients, right? So, the one on the right's easy to recognize. That's poor function. What about the person on the left? They need some more measurements, right?
And I think early on when people start doing echocardiography, they're interested in the squeeze and seeing does the heart function look normal or not. But really moving into diastolic function and assessing diastology isn't very hard when you have a little bit of help.
Right. So we'll go over that.
Here again,
just another example of bad systolic function.
And these are obvious cases, right? This person comes with B lines all over and a heart that looks like this. this is systolic failure all day, every day.
Yeah. Same with this one.
The interesting thing is when you see these, when you listen to these hearts, they sound a lot like healthy hearts. So if you're relying on auscultation, you're going to have some very long days.
Yeah. And this person this was actually a patient who showed up and told us, I have asthma, my asthma is acting up, and she was wheezing a lot. But she had pulmonary, bad pulmonary edema. That was her main problem. That's what was making her wheeze.
Cardiac asthma.
Yeah. Okay, now here's a patient who might show up with pulmonary edema, and looks like pretty reasonable left ventricular function, at least if you judge by
glance,
EPSS there. You can't see the apex, but still. What's the one thing you notice here is that the left atrium is huge, right? So that's a tip-off to diastolic dysfunction. Most of the patients, if not all, that you see with bad diastolic dysfunction are going to have a big left atrium because they have chronically high filling pressures. And so that's going to be your tip-off, the big left atrium.
I think when you're starting to do echocardiography, and we teach this after you're able to obtain the heart image from multiple windows, the next thing is just to really have a systematic approach, not just to your evaluation, but also your evaluation of cardiac images. We believe that in about 70% of people, you can get a good peristernal long axis view of the heart. And this heart gives you more information in 1 minute than you could get through auscultation for the rest of your life. You get a great view of the pericardium. You get to see the RV at the top of the screen, the LV. You work your way up to the mitral valve, the aortic valve.
So you're seeing RV up here. You're seeing the aortic root here, and then the left atrium.
Yeah. And when we look at that image, so we have the RV on the top, we have the aortic root, and then we look at that left atrium, and then we also see the descending thoracic aorta. A lot of times with the RV, the aortic root, and the left atrium, we like to think of that each one of those will occupy about a third of the screen, and they'll be about the same size. And when you see that huge left atrium that is larger than the overlying aortic root throughout the cardiac cycle, that's generally a marker for left atrial enlargement.
Yeah, and if you're looking for measurements, the aortic root should be less than 4 centimeters, and the left atrium in this diameter should be less than 4 centimeters. This one is more than 5, maybe 6, so that's going to be really abnormal. Also, the size of the left atrium in relation to the left ventricle should be usually about 1/3 or a quarter of the size, and this one might be even bigger. The chamber might be even bigger than the left ventricle, so that's obviously really abnormal.
And really what that reflects is the high filling pressures, right? Normally the healthy heart is young and elastic, it just accepts blood easily, but as the left ventricle stiffens and you rely more on the atrial kick, there's more resistance to flow, and then that atria starts to enlarge. And certainly that's a later sign as you get more advanced diastolic dysfunction.
Yeah, another example, the same thing. A lot of times you'll notice in these patients also, you can see the left atrium here is big or bigger than the left ventricle, and you'll notice that the LV wall is thick, more than 1 centimeter thick. It's hard to see it here, but if you increase the gain a little bit, you can see it's pretty thick there, laterally at least. Okay, the way to measure diastolic dysfunction, the easiest way, and this is pretty simple, is to just put the pulse wave Doppler gate just inside the ventricle, just inside the mitral valve. You don't want to see the valve leaflets, but just inside that area, and like this. And then
I think one of the most difficult things when doing diastology is actually the knobology, right? So you're going to drop a pulse wave gate in the mitral valve inflow, right? And then you're going to get your inflow velocity, your E and your A, and we'll show all that in a little bit. But then you have to get into tissue Doppler, and depending upon which machine you're using, so then you have to take TDI, PW, then sometimes you have to go back to TDI. But in the AI toolbox with the auto DFR, you simply hit the button. It drops the pulse wave gate generally close to the mitral valve inflow. You might have to adjust your image slightly, and it begins to get the E and the A measurements, and they come up on the screen. After you've saved that, it converts to tissue Doppler imaging. It drops the tissue Doppler gate along the medial mitral annulus, and then it starts to measure your E prime. And the fact that it's all automated step by step versus you manually manipulating the machine, hitting pulse wave, getting into the TDI. I don't know about you, but when I'm doing TDI, I usually will have to hit the buttons a few times before I actually get it into tissue Doppler imaging. And again, breaking down something complex and making it very simple, once you get the data which shows up on the screen, it becomes relatively easy to interpret.
Yeah, it's all the non-biology that becomes cumbersome, all the button pushing. But in the AI single button push really is much easier. So the difference between pulse Doppler and continuous wave Doppler is, at least one difference, is that when you pull up pulse Doppler, the machine is measuring the flow of blood right at that gate. And that's important because that's just inside in this case, just inside the mitral valve, and it's going to show you the mitral inflow. And that's in contrast to continuous wave Doppler, where it measures all along that line, which you don't want to use in this case. So you get something like this. So this is a normal E and A wave during diastole. So in a normal, healthy, young heart, most of the filling happens, the first peak here, happens with passive filling. So the ventricle contracts, and when it relaxes, it creates a vacuum, pulls blood into the heart, into the LV, and you get this first peak.
So the healthy heart is very elastic, right? And so in that phase where the blood is rushing into the LV, most of the movement happens in the E phase. So it's a high E wave versus the A wave, which is the atrial kick. There's not much left in the healthy heart, so you have a very small A wave.
Yeah, and once you understand this, it's easy to conceptualize that the atria doesn't do very much in a healthy young heart. It just adds this second little bump here.
And
cursor doesn't want to point to.
In the auto DFR, actually what you get is you get your E to A ratio. And what you would expect is a normal E to A ratio, right? 0.8 or more, less than 2. And the fact that you can just hit the button and all of a sudden you're getting your E and your A showing up. And in this case, it's pretty obvious. I mean, pseudonormal could confuse you. But on the screen, on the right-hand side, you get your E to A ratio, so greater than 0.8. So that's going to be normal.
Right. So if the E is bigger than the A, but the E isn't huge, that's normal. Okay. So this is your first abnormal image you might get. Is the E is smaller than the A. That's early diastolic dysfunction, and this is easy to recognize.
Yeah,
okay?
and with the auto DFR, your E and your A waves are labeled, making it even easier. So you don't even have to have a high-level understanding of this. And there that you see the passive filling with the E is very small, and then when you get the atrial kick, you see that A wave get very large, and then that is obvious diastolic dysfunction.
Yeah, like this. So when you get worse diastolic dysfunction, you get the E is towering over the A, more than 2 times the size of the A, and that's more severe diastolic dysfunction. You can see this left atria is huge, which would correlate with that.
And then on the screen, you're seeing that E to A ratio get more than 2. And so by understanding just some very fundamental things, understanding that your normal E to A ratio 0.8 up to 2, and then even though your E and your A, you're like, hey, my E is bigger than my A, it should be normal function, but when you see that E to A ratio get up to 2 or more, you can know that that is advanced diastolic dysfunction.
Yeah, and so they have really high filling pressures. So the pressure in the atria is very high. So as soon as the valve opens, the left ventricle fills, just because the left atrial pressure is so high, and then the atria kicks. But with that big atria and probably a relatively weak kick, you get a tiny little A wave. So that kind of explains why. So this kind of shows you the progression from normal to grade 1 early diastolic dysfunction, where you get a reversal of the EA waves, to grade 2, and this is a confusing part, is grade 2 diastolic dysfunction has a pseudo-normalization, so they re-reverse, And then you get to that one we just looked at where the A wave is towering over the or the E wave is towering over the A wave. That's late, or grade 3.
And I think this is where you lose people a lot, when you go from your normal and your pseudonormal, because they look so much the same, and the hearts themselves may have a similar appearance. Again, you have that E to A ratio, 0.8 up to 2. But that's where when you get into tissue Doppler imaging, right? A young or a healthy heart has good tissue Doppler velocities, generally more than 8 centimeters per second. And the fact that this actually goes in and drops the TDI gate along the medial mitral annulus, and we'll show an image of that in a little bit. As you see that E prime velocity get less or lower and lower, it's indicating more dysfunction.
Yeah, so if you measure tissue Doppler and you measure it at usually the medial mitral annulus is the best place to measure it. That's the lower waveforms here. So you're going to see as you go from normal to greater diastolic dysfunction, that E prime, which is the tissue Doppler movement it's just moving up and down toward the probe. So it's the medial mitral, the muscle right next to the medial mitral annulus, and the machine's just measuring the tissue Doppler and the movement of that muscle up and down and the speed of it. And as that gets lower, your diastolic dysfunction gets worse and worse. So that's pretty simple to comprehend and understand.
And it certainly becomes challenging if you don't have these features to be able to pick up these things. But the fact that you can go through it and get these values, especially the E prime, right? You got a low E prime.
Yeah.
I think that's very telling for diastolic dysfunction. And certainly when you're fluid resuscitating someone who has severe diastolic dysfunction, I think you can get into a lot of trouble really quickly with high volume resuscitation, or just how rapidly. They may tolerate the volume, but at a slower rate.
Yeah, and these people also will not tolerate being fluid down. So they're very touchy with fluid. You know, when they get fluid down, they don't like that because their LV is used to a high filling pressure. So they may look worse when they're fluid down. But then if you give them too much fluid too rapidly, they're going to get pulmonary edema. So the hardest patients to take care of probably. And bad diastolic dysfunction studies show that patients who are in septic shock with significant diastolic dysfunction have a higher mortality, which kind of makes more sense. They're so hard to resuscitate.
And by being able to guide the resuscitation based on what's actually going on with their heart is just invaluable.
Yeah. These are the patients you might want to do those measurements that we talked about on. This is where the machine, you just push one button, the machine puts the cursor there where it should be. This is a 4-chamber view. It's a little hard to tell with the tissue Doppler on, but this is a apical 4-chamber view, and the machine's putting the pulse Doppler gate right where it should be on the medial part of the annulus, on the muscle, next to the medial annulus.
Just inside the LV. Yep.
Yeah.
And that's a great spot, and then it's just measuring that velocity of movement. How fast is that tissue moving?
Yeah. Next image here shows the gate in the correct place and then the waveform that you get. And what you get is E, this is E, and that's an A, so E prime, A prime. And so you're going to see that typical waveform. Actually, I'm wrong. That's E prime, A prime.
Yep, there
E
you go.
prime, A prime. So in systole.
And I think that shows how confusing that this can be.
Yeah.
Right? Without having those on there. But when in the next slide, it'll show you, all of a sudden it starts labeling the E prime for you.
Yeah.
And I think this becomes much more useful. It can be confusing.
So just as the blood, as you get the forward flow through the mitral valve and diastole, you get movement of the mitral valve away from the probe, so going in the downward direction. So this is actually the tissue moving in the downward direction during diastole, and you get these two movements because of passive filling, atrial kick. Okay, so and then as you get worse diastolic dysfunction, it's this first downward deflection that you care about the most, the E prime. And you can see here the machine picks those things out and puts starts actually just labeling the E prime, which is pretty cool.
And the fact that it labels it, but also you get those values up on the screen. Even if you don't know much about the image or the waveforms, you're going to start to get your E to E prime value.
Yeah. And here is an example of someone with pretty significant diastolic dysfunction, and the machine is picking up on where the E prime is, and it's reporting out there, 0.06 meters per second. A lot of machines measure centimeters per second, and so when you look in textbooks or look at values, it'll say rather than 0.06, it'll say 6. So it's 8 centimeters per second. Anything under that is diastolic dysfunction. Okay, so again, this is the same chart we showed earlier, but again, just to show that when you're looking at tissue Doppler, you're looking for just this first downward deflection, which is E prime, and as that gets lower, smaller and smaller, when you get to 8, that's anything 8 or under is considered diastolic dysfunction, and then as you get worsening diastolic dysfunction, it just gets worse and worse on the right side of the graph here.
And certainly, when you get those values on the screen, you can reference these charts. Not hard. I think people get caught up in a lot of the values and the information, but the reality is looking at that E to A ratio, and then looking at your E prime, and then if you want to, you can get to your E to E prime ratio, but much more than that, I don't think it's necessary.
Yeah, and the time you really need tissue Doppler is in this pseudo-normal period here where your E to A will look normal, and then you want to get that. But remember, these people will have usually thick LV wall, and they'll have a big left atrium. So that's your tip-off in the first place. Okay, so let's go on to valvular problems causing dyspnea. Most valvular problems, the number one symptom is dyspnea. So that's good to know. We don't think about that very much, but I'm sure if you're an experienced emergency physician, you've seen that. You thought you're dealing with someone with a bad LV, and they have a bad mitral valve. So that's pretty common. So calcific disease is common commonly causes aortic stenosis. About 1/3 of elderly patients or patients over 65 will have some sclerosis of their aortic valve to the point where it might look like a big clump of calcium. But that doesn't necessarily mean they have aortic stenosis. You need to do at least a little bit of measurement. Rheumatic disease is common, not in the United States, but elsewhere in the world. So if you're going to do any travel medicine, you better know that, because you're going to see a lot of it. And so dyspnea is really common around the world from rheumatic disease. We see a lot of infections, IV drug users and other people of the valves. Right-sided infections of the valves are common in IV drug abusers, but left-sided endocarditis is the most common. And then ischemia can cause, of course, papillary muscle rupture, which can be hard to diagnose. And then aortic dissection is something you always have to keep in mind. And your tip-off there will be aortic regurg, which always has to make you suspicious for aortic dissection.
Yeah. I think one of the fallacies that people think when they think about valve problems, they're thinking about murmurs. Yeah. And at our small facility where we can get an echo once a week, that person could go a long time with a very significant valvular problem that goes undiagnosed. And sometimes severe AS has no murmur when it's so advanced. If they haven't presented previously, but it's an extremely easy diagnosis when you actually look at the heart.
Yeah. And if you're relying on a stethoscope to make a lot of these diagnoses, especially someone ruptures their papillary muscle, that person is going to be extremely sick and tachycardic, and good luck trying to hear a murmur. It's just going to be extremely difficult. Let's talk about aortic stenosis first. So it's fairly common. 4% of patients over 65 have significant aortic stenosis. Dyspnea is the most common symptom, short of until they get to the point where they're really sick, and then they might actually have cardiogenic shock. And maybe pulmonary edema even. But that's going to be kind of the end stage. So dyspnea is going to be the time when you can, someone comes in with exertional dyspnea, that's when you can pick it up. They can also, of course, get dizzy and pass out, but dyspnea is the most common. So always keep it in mind. It's easy to rule out. Like we said, the parasternal long axis is kind of your go-to. And if you can see the aortic valve open like this, they don't have aortic stenosis. You just rule it out. You can look at it transversely too, but seeing two of the leaflets in the parasternal long is just fine if you can see them open like that. Papillary muscle rupture is something, like I said, it's hard to diagnose, especially if it's a full papillary muscle rupture. That person is going to be very sick. They're going to have pulmonary edema and be in shock and be very tachycardic. And so it's hard to diagnose anything in the heart when the patient's extremely tachycardic, but you have to have high index of suspicion for this in a patient with this picture. It's going to happen 3 to 5 days after acute MI, so the troponin is going to be high. And if you don't figure this out quickly and get them emergent surgical repair, they're going to die pretty quickly.
These people come in really sick, and being able to make that diagnosis within a few minutes is really necessary. Without that, they'll just be dead.
Yeah, and you need to think about, putting color across, behind the mitral valve, but just realize that when they're extremely tachycardic, it might be hard to interpret. So, you need to look closely, and actually looking at that point, slowing the image down, freezing it, slowing it down, and actually looking at what the valve leaflets are doing. This is an example of someone who's not that terribly tachycardic, but has a partial papillary muscle rupture. And so what you're seeing there is the lateral mitral leaflet, which is the posterior leaflet, to the right on this image, is actually prolapsing backward a little bit. It's hard to tell on this image, but if you zoom in on it a little bit, here's another view. It's the leaflet on the bottom. You can see it's kind of sliding under the other leaflet. And, of course, if you turn color on here, you're going to see a big leak.
And it's subtle. Visually, it's very subtle. Here's the zoomed image.
Yeah. But here's the big leak. And when we checked an old echo from just a year ago on this patient, they didn't have any mitral regurg. And they came in with acute pulmonary edema, really pretty bad pulmonary edema, and what looks like a pretty good looking left systolic function. So that's kind of the tip off. But again, if you don't put color on this valve, you might not even notice that subtle valve problem.
And frequently what we do as a quick screen is we drop a color box and we include a little bit of the LVOT, the aortic valve, the mitral valve, and the left atrium. And then when we see a significant regurgitant jet, whether it's aortic insufficiency or mitral insufficiency, then we'll move the color box down so that we can see the entire left atrium. And certainly when you see color regurgitant all the way back to the pulmonary vessels, you have severe MR happening.
Yeah, you can see the jet fills really the entire atrium, and any jet that fills more than half the atrium starts to make you wonder, is this why the person has pulmonary edema? In this case, it was. This is an example of aortic insufficiency, and the way that you judge aortic insufficiency is what, the height. We talked about measuring, looking at the outflow tract in the parasternal long axis view here, but how much of the outflow tract does that jet take up? And this looks like it's probably taking up more than half of the outflow tract. This is a problem that nobody has normal aortic regurgitation. Some people have a little bit of wisp of mitral regurgitation, and they're young, healthy people, and it doesn't matter, but nobody normally has aortic regurgitation. So any sign of aortic regurgitation should be investigated further. Okay, let's talk about pulmonary embolism. Of course, that can cause dyspnea and can be extremely hard to diagnose. This says 28% of ED patients with PE get misdiagnosed. I'm surprised it's that low. This is shocking, 54% of hospitalized patients. So what happens is people get hospitalized for other things, they're dyspneic and someone sees, the chest x-ray again. There's a little maybe pneumonia on the chest x-ray, so they get labeled with pneumonia, and if they're sick enough, they get admitted, maybe discharged. And then, when it's obvious it's a P later on, you look back and that's probably not pneumonia. So that's a common scenario. Incorrect diagnosis, could be heart failure. Acute coronary syndrome is common. People have chest pain and they just kind of maybe their troponins elevated a little bit, so they get admitted. And the reason the troponin's elevated is because they have a PE. So if you don't think of that, you can easily miss this diagnosis. What you look for on echo this is pretty obvious, big right side, RV bigger than LV. The RV should normally be smaller than the LV, and usually about half to 3/4 the size. When it approaches or gets bigger than the LV, you need to think
certainly
what's going on here.
Once you get to 50-50 and above 50-50, again, this is not a subtle diagnosis.
And you can see here that the septum is bowing to the left, which is never good. So right here, you can see the septum bowing the wrong way. If you look at a short axis view of the same situation, you can see septal bowing or straightening, and that's the D sign. So that's the flat part of the D and the round part of the D. So you also sometimes see clot in transit here in the right atrium. This patient happens to be crossing patent foramen ovale, and so you can see it on the left, but that's a little less common. But if you think you see something flopping around on the right side of the heart, that's often clot in transit, so it's not as uncommon as people think. And this is something that's not done often enough. If you see a clot, or you think you have a patient who may have a PE is even on the differential, go look at the legs. It's a much easier exam than a cardiac exam, and you might find, if you find a clot in the leg, a DVT, and the patient came in with acute dyspnea, I think you've just narrowed your differential there pretty nicely, and you're gonna have a much higher suspicion at that point for working up PE.
Certainly in the acutely dyspneic patient who's tripoding, they won't lay back, they maybe have COPD or something, the cardiac windows are horrible. Generally you can get to the groin or the popliteal fossa.
Or when you see, you see this big right side and you're thinking, the person looks pretty sick. Is this a massive P or a submassive P, or should I give them, I'm not 100% sure of the diagnosis, but I kind of want to give them TPA. Look in the legs. If they have this picture and they're pretty sick, and they have clot in their legs, the diagnosis. Give them the TPA.
And I think anytime you can get more reassurance when you're giving lytics, it's helpful, right? So they're usually hypoxic, hypotensive. These are very sick patients.
Yeah, statistically, people who have a PE have about a 50% chance of still having clot in their legs. So look, an easy scan to do. Okay, let's talk about pericardial effusion. Also, the greatest, the main symptom, or the number one symptom of pericardial effusion, is dyspnea. And people think of shock and Beck's triad, which doesn't really exist most of the time. But dyspnea is by far the most common symptom, and if you just look, pericardial effusion is easy to see. Then it's a matter of, is it tamponade or not, and you can work through that, but the first thing is to recognize it.
That fluid, again, makes the cardiac window easier to image, just by having it there. In
the subcostal view, this is a one diagnosis that the subcostal view is best at. So if you think you see a small pericardial effusion in one of the other windows, like peristernal or apical, go to the subcostal. Sometimes it'll look a lot bigger. Like I said, dyspnea is the most common presentation. Patients will often be tachycardic, sometimes hypotensive. And depending on what's causing it, they can have a sudden cardiovascular collapse. This is a pretty good sized pericardial effusion. And then, you want to know, is it tamponade? Is there really diastolic collapse? You can see the RV collapsing there, but the question is this diastolic collapse? So is the RV free wall collapsing in diastole, or is that systole, or what's going on there? So the one way you can clear that up is to put a M-mode cursor through you have to get a nice horizontal peristernal long axis, and then put the cursor through the free wall of the RV and also through the anterior leaflet of the mitral valve. And what you'll see is you'll see that if you look at the E wave, when you're looking at the anterior leaflet, you're seeing the E and then A. But you look at the E and you say, okay, there's the E of the mitral valve, and go up here and look at the free wall of the RV and say, yeah, it's collapsing right at that point. So that's diastolic collapse of the RV free wall and diagnostic of tamponade. Now you don't have to get that complicated. Okay, if you have a moderate to large effusion and you have to have a big IVC, you can't have tamponade with a small collapsing IVC. It's not possible.
Certainly, if you see that big pericardial effusion and you have hemodynamic collapse, you look at the IVC, you see it is plethoric, it's going to be tamponade.
Yeah. If you see a RV free wall collapse and you see or if you think you see it and you think you have tamponade and you see a small collapsing IVC, give the patient some fluid. Either way, give the patient some fluid, because if they're in tamponade, fluid helps. But you can't have a pericardial effusion, be fluid down, and have tamponade physiology that gets better with fluid. So you always want to give fluid first, but you can't really have tamponade without a big IVC, at least before you stick a needle in it and look at the IVC. Okay, pericardiocentesis. Wouldn't be an advanced echo webinar if we didn't talk about this. So, of course, ultrasound makes tapping a pericardial effusion much safer. Probably the only way to make it very safe. So basically, put the needle into the largest fluid collection in the pericardium, close to the chest wall. Easy, right? And that's usually not the subxiphoid or subcostal space. Okay, so this is the best place to see a pericardial effusion from, but probably not during a pericardial effusion. You can get at places on the left chest, whether it's the apical, from the apical approach, or more the peristernal. Probably somewhere in between that would be the best approach. If I'm going to use a phased array probe, though, I'd say when I used a phased array probe to do this, I would get a kind of an apical view, or somewhere between the apical and peristernal, where I could see that the effusion was fairly big and usually lateral, and I could put the needle medial on the chest, medial of the probe, and aim it into a space where my needle trajectory was not aimed right at the heart, but kind of scything past the heart into the pericardium, into a deep part of the pericardial effusion that wasn't, so the trajectory wasn't aimed directly at the heart, if that makes sense. So this is a good example. I'd put my needle trajectory up here somewhere, and I wouldn't aim there, I would aim over here. So I have quite a lot of room to push the needle in there without hitting the heart. by the way, if you stuck the needle into the heart here, it's not a big deal if your plan is to put a catheter in. So if you stick the needle into the heart, you get blood back and you go, oh gosh, I'm in the heart. If you have a single needle hole in the heart, the solution to that problem is to get a catheter into the pericardium, leave it in for a couple days, and that little hole will probably be okay. And so eventually get the needle down here, get a wire in, get a catheter over it, and then you can just let it drain. What I like to do is get the needle in, don't draw any fluid out initially. If it's bloody fluid, you want to do a bubble test to make sure you're really in the right place. You'll see bubbles in the pericardium. If you get yellow fluid out or anything other than blood, just get your wire in right away. You'll see the wire go in, and then your wire's in the pericardium. The catheter is going to end up in there. Pretty simple procedure, especially with a fusion this big.
And I think throughout the time that we've been practicing, you've seen that progression from the blind approach to the apical approach with the phased array, and then more recently being able to use a linear probe and actually be able to see your needle the whole way. As we do more and more needle-guided procedures in the ER, it just becomes another spot with fluid, and it's much less intimidating.
Yeah, I remember doing a pericardiocentesis on a cardiac arrest patient and during the EMS ride-along in the patient's living room, and the medic's handing me the needle saying, there's a doctor here, you do this. And I'm like, okay. And I got blood back, and I didn't know where I was, and the patient remained in cardiac arrest.
The
So
fact
not
that
very
you can,
satisfying procedure.
Yeah, but the fact that you can make the diagnosis so quickly, I mean, pericardial effusion or tamponade without ultrasound is just, it's like impossible. A Brecht's triad, that's ridiculous.
Yeah. So let's go back to the beginning of this. This was a patient in cardiac arrest who we realized right on arrival, big pericardial effusion. Pretty quickly, the only thing you can see with a phased array probe is just a single dot there where the needle, some part of the needle is. And so you need to do a bubble test if you get blood back. You can see that they just pushed a little, they basically, you don't need to put any bubbles in there, just pull whatever fluid out is in there, pull a little bit, a few cc's of it out and push it back in very quickly, and you'll see some bubbles. And then the tip of your needle must be in the pericardial space, and then either get a catheter or a wire or something in there. In this case, just draw back some fluid because they're in cardiac arrest. You don't have to draw much out to solve the problem, tamponade, because the last few drops are the thing that cause tamponade. Here's an example of a wire going in a similar position. They're at the apex, aiming down in, next to the heart into the effusion, and then the needle is already out here, and the wire is right there. You can see it going in there, right there. So your catheter is going to get in the right place. Okay, so the more modern way, the way that I like to do pericardiocentesis now, is to actually use a linear probe. And the way that you do this is usually you can do it lateral to medial, but I found medial lateral to work most of the time better. And what I do is whoop, sorry, user error. I will I'll put this side of the probe medial, so this is medial, this is lateral. I'll purposely look at the lateral edge of the sternum here, so you see the bone there and the shadow behind it. And then just about an inch or around there, lateral to the sternum, you'll find the internal mammary. So this is the heart down here, this is the pericardial effusion. You'll see the ribs up here. And then just behind the ribs, you see this vessel. This is the artery that you don't want to hit when you start medial to lateral. And usually you can go lateral to that. And this effusion will keep getting bigger and bigger as you go lateral usually. And so if you use this approach, just start here and then walk your probe out lateral, note where the artery is, and then go out here lateral to it, keeping it in view until you get lateral to it, or do it right here, but make sure you don't hit the artery. You can put the needle right here and it'll be fine. So here's an example. You can see the needle coming down clearly right there. This is actually a rib, not the sternum, because we're out more lateral. But you see the needle came in like this, and it's right here. You can see where the tip is here in the next view. You can see the tip right there. There's the tip. Tip just punctured the pericardium. There's the bevel on the tip. Very clear. This is a resident doing this who's never done it before, and it's still pretty crystal clear where you are. And then there's the wire going in. So you see the needle here coming medial to lateral, and you see the wire going into the pericardium there. So let's look at that again, because it's a pretty nice image. There's the wire feeding into the pericardium. No doubt about where you are here, and you saw the needle the whole way, so there's very little chance you're going to go in the wrong place or hit the heart. And then this is where it ended up in the patient, pretty far out lateral. But you don't really have to pay attention where you are in the chest wall. Once you see, if you're on top of the pericardium, you're seeing the pericardial effusion. Once you get away from the sternum and that internal mammary artery, don't worry about hitting anything else, because if you can see the effusion, there's nothing else in the way.
Thank you for joining us for today's webinar. There was a lot discussed today, so the most important key takeaway is that a methodical approach to your cardiac scanning is essential. Evaluating dyspnea can include lung ultrasound, the evaluation of diastolic function, the interrogation of valves, the detection of pulmonary embolism, and the detection of and treatment of effusions and tamponade. Please don't forget to join us for the final part of this series, where we will address the patients presenting with chest pain.